Thank you. As far as my disclosures, I'm a consultant and receive research support from Smith & Nephew Endoscopy, also a consultant, have stock in A3 Surgical. I'll offer 6 keys to what matters as far as indications. The first key is trying to be as sure as you can that it's a hip joint problem, and that seems obvious, but when we published the first scientific paper on hip arthroscopy in athletes, we found that 60% of intraarticular disorders went unrecognized during the first 7 months of initial treatment. We looked at a paper looking at various clinical assessment tools, and basically what we found is your history and your physical examination are going to be your most powerful clinical assessment tools. And as a backdrop for that, we've learned that extraarticular disorders may mimic and sometimes coexist with intraarticular problems. We think of hip and lumbar spine disease, and in sports, this is especially common for athletes that participate in sports where rotational velocity is a premium, especially golf and baseball. We know there's a high correlation between athletic pubalgia and hip joint problems, and the most simplistic explanation we can offer, especially with impingement, is that because of reduced rotational motion of the hip is compensated by increased pelvic motion, which puts stress on the pelvic stabilizers with breakdown of those structures. As far as imaging studies, these must be interpreted only in perspective of the clinical assessment. You don't want to be lured by false positive interpretations, and you don't want to be dissuaded by false negative studies. Keep in mind that x-rays, as Chris Larson has shown us looking at athletes at the NFL Combine, 87% of all x-rays, regardless of symptoms, showed some findings of impingement, so it's almost ubiquitous. As far as magnetic resonance imaging, I think at best these studies incompletely assess the existence of hip joint pathology, but oftentimes the imaging findings may not be relevant. Keep in mind that athletes that have participated in long careers may have all kinds of findings on MRIs that may have no relevance at all. As far as diagnostic intraarticular injections, these can be helpful to substantiate the clinical relevance accompanying the imaging finding that we see. It's also helpful to differentiate how much the hip is serving as a pain generator when there are other coexistent problems. And I think it's important to use a long-acting anesthetic to reliably get a response. We use ultrasound in the office, which is very simple and atraumatic for the patients. It also gives you a real-time assessment of the response to the injection. Now, it's important that your athletes can predictably provoke pain pre-injection so that they can repeat post-injection to see how much pain relief they get for a valid interpretation. Also, remember that your athletes can generate a lot more force on their hip with sports than you can generate just passively examining their hip. So sometimes you need to send them to therapy or to the training room to stimulate and reproduce the activities to determine the response. The next key is picking the right patient. Certainly clinical circumstances that are potentially amenable to arthroscopic intervention, but you also want to make sure your athlete has reasonable expectations of what you may or may not accomplish with the operation, because you can do the greatest operation, but if your athlete had unreasonable expectations, it's going to be deemed a failure. The next key is that the indications evolve with your experience. As you're getting started, start with simpler cases. It's okay to refer those complex cases early on. More of them are going to show up in the future, so start simple and build up to more complex procedures. The next key is not to be in a hurry to operate. There are very few problems that necessitate prompt or immediate surgical intervention. Now, the flip side of that is that sometimes it's evident that they need surgery, and there's really no advantage to just delaying it arbitrarily. But enthusiasm is rarely an attribute as a surgeon as you're addressing these problems. Also, and this is self-serving, but if an athlete has suffered with a problem for a while, then they're more likely to be satisfied with the surgical result that you can offer them. Now, as far as femoral acetabular impingement, remember that many athletes participate in long active sports careers with all kinds of weird-looking x-rays. Now, the flip side of that is Professor Gons has referred to cam impingement as the silent killer of the hip, because there's advanced articular damage before the symptoms or imaging becomes very evident. And that's been consistent with our findings. We published our results at FAI in athletes. 90+% had grade 3 or grade 4 articular damage at the time of surgery, so we're intervening late in the disease process. Regardless of how suddenly the symptoms occurred, remember this is simply the culmination of the cumulative effect of a lifelong disorder. But once somebody becomes symptomatic from the secondary damage due to FAI, it's unlikely that's just going to get better and go away. It's simply a matter of you try to manage the symptoms as best you can, or you recommend surgery. The next key is ask yourself, well, is it harmful if I let an athlete continue to play with evidence of joint pathology? And really, lack of immediate surgical intervention is unlikely to be harmful to the athlete. Remember, with FAI, it doesn't matter how acute their symptoms are, it's still the culmination of a lifelong process. It's unlikely the condition will get worse and the athlete not know it. If the symptoms are stable, I think it's okay to go ahead and continue to participate. Will they cause more damage? The answer is it's sure possible, but it's not going to happen without them knowing it. If the symptoms are worsening, then it's probably better to be proactive and recommend surgery rather than simply wait until it gets completely disabling. And lastly, I think assessment should be as complete as possible, looking at all etiological factors. Keep in mind that most hip disorders are multifactorial. It's sort of the perfect storm of enough things coming together just wrong to create the problem. And you may never identify all the factors. And for example, with impingement, it logically explains the secondary damage that we see in our athletes. But how and why are some athletes lifelong compensators being active with all kinds of odd-looking hips? And we really look at two modes of failure. One failure is at physiologic loads, and again, FAI is an example where with the altered joint morphology, it causes breakdown of the joint at forces that would normally be tolerated by a healthy hip. Correction of the impingement may be successful and provides a more favorable long-term outlook. But we also look at failure due to supraphysiologic loads, and this is where athletes are simply pushing their body beyond the physiologic limits. Some big offenders with this are dancers and gymnasts. For these conditions, the primary treatment is non-operative, especially looking at modifications, trying to get them on a good conditioning program where perhaps you can expand their physiologic limits. Under these circumstances, surgery is less often successful. Now, you throw into that some sports and athletes where their passion exceeds their physical abilities, and you take a poorly conditioned athlete, they have less reserve and they have less ability to compensate for these supraphysiologic loads. Then you take that and throw in a little dysplasia, and you've complicated it even further. But just one brief conclusion for you is I would state that problems and poor results associated with hip arthroscopy are at least as much a problem and a consequence of poor choices as they are poor technique. Thank you very much.
Thank you very much, Thomas.